Good evening, guys. Today we'll be talking about rickets, calcium phosphate metabolism, and how the growth plate changes in rickets and some of the bony changes. So, rickets, what is rickets? It is a defect in the mineralization of osteoid matrix caused by inadequate calcium and phosphate deposition prior to closure of the physis. I repeat, prior to closure of the physis. It is a disease of growing bone. So if this deposition doesn't happen, like in the case of adults who have already fully grown, it leads to something called osteomalacia. And if it occurs in growing children, it's called rickets. For the deformities and the things that occur in rickets to occur, the bones need to be growing basically. Okay, coming to the next history. So it was common in children living in crowded, poorly lit alleys in northern Europe. So that's how it was discovered. And a few people, what they did was they took a few children, radiated them with UV light from a vapor lamp, and noticed that the rickets went away. And also, one more person found out that if they give the children cod liver oil who had features of rickets, the rickets would go away. So they found that ultraviolet light and cod liver oil, which was rich in vitamin D, were two ways to prevent rickets. So, coming to calcium. So the total calcium content in the body is about 1 kilogram, and the most of it is in the bones, and only 1 gram is present in plasma and extracellular fluids. The normal range of calcium in the blood is 8.8 to 10.8, and the body is extremely sensitive to calcium levels, and there's a lot of systems in play to prevent the calcium levels from going above 10.8 or dropping below 8.8. So calcium absorption is an active process, and absorption from the kidneys occurs with the help of PTH, but the absorption from the gut is wholly dependent on vitamin D. And if we do consume, a regular person consumes zero point 0.6 to 1 gram of calcium a day, and out of that zero point 0.6 to 1 gram, if suppose they consume 1 gram, only one fourth of that gets absorbed. So if 1 gram is of calcium is taken, only 250 milligrams of it gets absorbed, and the rest is excreted in feces. So remember that while dosing calcium in summer. So some of the things which help hinder calcium absorption are fusitin, phytates, oxalates, citrates. Phytates are mainly your lentils and soybean, sunflower kernels, walnuts, basically your nuts, and rice, maize, wheat, etc. The most calcium-rich foods are mainly dairy products: milk, cheese, yogurt, cereals fortified with calcium, and green leafy vegetables. So also rapid intestinal movement, shortened intestine, and diseases like sprue, ileitis can all interfere with calcium absorption. And bile salts can improve calcium absorption because they break down fat. So what happens is, if fat is there, it forms non-absorbable calcium fatty acids, and that gets excreted. So if bile is there, it's good. It helps calcium absorption. So how is this all regulated? We know that if the body's calcium drops enough, it secretes a hormone called PTH from the parathyroid glands, which are four tiny glands on the back of the thyroid. So, what does PTH do? PTH firstly acts directly on the bone, and it acts on the bone and increases calcium and phosphate release from the bone. The main job of PTH is to increase calcium levels in the blood by hook or crook. Whatever it does, it has to increase calcium levels in the blood. So, it takes it from bone, it increases calcium reabsorption from the kidney, and it increases calcium levels in the blood. Phosphate, what it does is it increases phosphate levels in the blood by increasing bone resorption, because if from bone is resorbed, calcium and phosphate are released into the blood. Whereas on the kidney, it acts a little differently. It increases calcium absorption but promotes phosphate excretion or phosphaturia. Another important thing which PTH does is it activates 1 alpha hydroxylase, and this 1 alpha hydroxylase is an enzyme which converts vitamin D from its inactive form to its active form, which is 25 hydroxy vitamin D to 125 dihydroxy vitamin D. So, what this activated vitamin D does is it increases calcium phosphate reabsorption from the gut. PTH does not increase calcium and phosphate reabsorption from the gut. The only thing that can increase calcium and phosphate reabsorption from the gut is vitamin D. So calcium and phosphate released from the bones, calcium and phosphate reabsorbed from the blood, calcium reabsorbed from the kidneys, and phosphate excreted in the kidneys. These are all the functions of PTH. Okay. And of course, PTH acts indirectly on the intestines through vitamin D. Now, phosphate total content 500 to 600 grams, and a normal range is about 3 to 4.5. Rich sources of calcium are seafood, as you can see, lentils, soybeans, Greek yogurt, and cheese. Basically, cheese and Greek yogurt are rich in both calcium and phosphate. Vitamin D. Two main types are ergocalciferol and cholecalciferol, D2 and D3. Both D2 and D3 are fat soluble and similar to cholesterol with strong anti-rickets properties. Vitamin D2 or ergocalciferol is obtained from the diet by ultraviolet radiation of ergosterol. Ergosterol is a component found in foods, especially mushrooms, and then that is irradiated. We get ergocalciferol, whereas vitamin D3 is produced by the body when ultraviolet light falls on the skin and 7-dehydrocholesterol in the skin is converted to vitamin D3. I'll show you here. So, body synthesizes 7-dehydrocholesterol, deposits in the skin at a concentration of 3.2 micrograms per gram of skin. So, if ultraviolet light falls on the skin, it converts it to vitamin D3 or cholecalciferol, which is why they say sunlight is important for us when it comes to vitamin D production. So, what activates vitamin D? Hypocalcemia, because hypocalcemia stimulates PTH, and high levels of PTH activate 1-alpha hydroxylase, which convert the inactive form of vitamin D to the active form of vitamin D. You can see here 25-dihydroxy vitamin D, 1-alpha hydroxylase acts because of PTH, and it's converted to 125-dihydroxy vitamin D, which goes to the gut and increases calcium and phosphate resorption. Vitamin D's activation is inhibited by hyperphosphatemia. So, in case of renal failure, people are unable to excrete phosphorus. Phosphorus builds up in the blood, which increases something called FGF23. FGF23 prevents or inhibits vitamin D activation. Calcitriol also inhibits vitamin D activation. Calcitriol is nothing but a synthetic form of vitamin D. So, it increases calcium levels in the blood, but also blocks the conversion, and it increases calcium reabsorption from the gut. So, we no longer need vitamin D, so the vitamin D activation is inhibited because calcitriol is doing the job of natural vitamin D. So, since vitamin D's precursors are fat soluble, anything that produces steatorrhea or anything that causes a loss of fat in the diet cause a difficulty in absorption of vitamin D. So, what are the minimum daily requirements of calcium and phosphorus in adults and children? Adults 400 to 500 milligram, and children 400 to 7 milligrams of calcium respectively. Phosphate 1000 to 1500 milligrams in both adults and children. And in adults, the vitamin D is 100 to 400 international units. And as you can see, children require a higher amount of vitamin D per day, which is 400. So, so resorption of phosphate by renal tubules is highly sensitive to the hormone PTH. I told you, if PTH is acting on the kidneys, phosphorus is excreted. Etiology of vitamin D, multiple causes: calcium deficiency, etiology of rickets, phosphorus deficiency, calcium deficiency, of course, which makes sense. Because rickets is a mineralization disorder. So if there's a deficiency of these minerals, calcium and phosphate, it's going to cause rickets. Nutritional deficiency of vitamin D, and vitamin D dependent rickets type 1 and 2. I'll talk about all these other types of rickets in another video, but for now we'll stick to nutritional rickets strictly. So the pathophysiology of nutritional rickets. So if there's insufficient 125-dihydroxy vitamin D, which is the active form of vitamin D, what happens is there's poor calcium absorption from the gut, and whatever calcium we ingest goes out in feces. And eventually the body's calcium stores wear out, and it leads to hypocalcemia and hypocalciuria, loss of calcium in the urine as well. So in response to this low calcium levels, the body secretes which hormone? PTH, of course. And what PTH does is it increases blood calcium by mobilizing calcium from the bones and increasing reabsorption of calcium in the kidneys. So what happens is parathyroid also reduces phosphate reabsorption in kidneys, leading to phosphaturia. I told you that. So what happens is PTH acts continuously on the bone, so the bone resorption is excessive. New bone is also being formed, but the bone is not being mineralized because more of the minerals are being pulled from the bone by PTH. But there is osteoid formation in the bone, and the bone is trying to form new bone, but there's not enough calcium to mineralize it. So overall, there's a negative balance with not enough calcium phosphate to properly mineralize the bone. So the bone becomes weak and easily deformed, which leads to the all the deformities that occur in rickets. This is another flowchart you can go through. You can pause the video. Pretty much explain what I explained only. So the normal physis has a resting zone, a proliferative zone, a maturation zone, and a hypertrophy zone. The proliferative resting zone is just a storage area for minerals and important stuff that helps with growth. Proliferative zone is where the cell division and a growth in length of the bone occurs. Maturation zone is when the cells become larger and around the maturation zone is nothing but the zone here, and this is the zone of hypertrophy. The zone between the proliferation and the hypertrophy zone is the zone of maturation, and the cells grow even larger in the zone of hypertrophy. The cell nuclei shrink, and this is the most important zone in rickets, the zone of provisional calcification. So what happens is the blood vessels grow from the metaphysis into the zone of provisional calcification, and the cartilage matrix between these vessels and the columns becomes calcified. So in this zone only, there is no calcification occurring. So the defect in the physis occurs in the zone of provisional calcification. And the zone of primary spongiosa is the metaphysis zone where the calcified cartilage, which is calcified in the zone of provisional calcification, gets surrounded by osteoblasts and bone is formed. Okay. So what happens? What changes occur in the physis? So normally the cells are arranged in nice columns. You can say, yeah, the cells are arranged in nice columns. Whereas in rickets, what happens is the cells are tightly packed and irregularly arranged. There's no column pattern. Like you see, this is a nice column pattern. There's no column pattern here. It's haphazardly arranged. And the area where the blood vessels invade and calcification should occur is very disorganized. You can see these are the blood vessels in black dots, the black beaded lines invading, and you can see these are invading nicely. Here you can see the blood vessels are unable to invade because of the haphazard and non-columnar arrangement of the um, uh, cells. So the excessive growth of cartilage cells not only makes the plate taller, you can see the plate is much taller. Also, the plate will be much wider because the cells are not only arranged like this, but the excessive number of cells also tend to expand the growth plate. Okay. So instead of this arrangement, we get this arrangement. So what happens is why these vascular buds growing into the between the columns is important. Why these vascular buds growing into the columns are important. So the vascular buds are actually the ones that restrict the excessive growth of the cells vertically. So as you can see here, I showed in the previous slide, these vascular buds are nicely grown and touching the cells in the columns. You can see they are unable to invade the columns because the cells are all haphazardly arranged, so they are unable to destroy the cells. So what happens is the vascular buds from the metaphysis grow into the growth plate of the physis and form into rigid tunnels of calcified cartilage around the empty spaces around the cells. So these are the tunnels and these are where the blood vessels grow into it. And it creates a honeycomb pattern on the metaphyseal side of the epiphyseal plate. And these blood vessels grow into these honeycombs. So what happens is the growth of these blood vessels normally destroys the base cartilage cells and the cartilage plates between them and helps control the length of the cartilage columns. In rickets, these tunnels do not form because there's no calcium deposition and there's no mineralization, so there's no channel which is hard and set for the blood vessels to grow into. And so the blood vessels cannot grow into the cartilage, so the columns keep growing downwards without being broken down because there's no blood vessels to break down and destroy the lower cells in the columns. And these delicate blood vessels cannot grow into tunnels. As a result, the cartilage in the cells proliferate at a normal rate, but the degradation does not occur in the normal rate. And hence, this leads to haphazard growth of the column cells both vertically and horizontally, increasing the size of the growth plate both vertically and horizontally. Another important feature that occurs in rickets is something called cupping. So cupping is when the epiphyseal area of the bone gets indented inwards because of the pressure from the growth force. So what is that? I'll explain. So what happens is, as the cells expand downwards, because the metaphysis is nice and calcified and contains bony tissue, the metaphysis is a hard, solid structure and does not allow the growth pressure to push into it. And what happens is, when the growth pressure from the physis pushes into the metaphysis, this metaphysis exerts a force back, and this leads to growth of bone in the direction of the physis. So what happens here is, in case of rickets, we know that the metaphysis is the cells in the metaphysis not being calcified properly. So there's only a deposition of osteoid matrix here, and it does not form a hard structure which can resist the growth pressure from the physis. So what happens is, when the growth pressure from the physis hits the metaphysis gets indented, and this is what leads to widening and cupping. You can see here the growth pressure from the physis indents into the metaphysis, which leads to cupping, fraying, and all the other deformities of rickets. It is because of this. So, and what happens is, the overly abundant osteoid produced by normal osteoblasts generates wide osteoid scenes, but there's no blood vessels to absorb the osteoid, and the osteoids continue to grow downwards and may even extend down into the diaphysis beyond the metaphysis sometimes. So, what are the bone abnormalities in rickets? The bones are smaller, lighter, and deformed as they contain less calcium and phosphate. Collagen is produced at a normal rate. The reduced deposition of calcium in the collagen leads to decrease in the volume of mineralized bone without a decline in the osteoid matrix. So the osteoid matrix normal amount, calcium and phosphate lack. So there's no mineralization of the osteoid matrix, which leads to all the deformities of rickets. Okay. So the clinical features. Remember, in infants and young children with severe rickets, the main and the initial clinical features are listlessness, irritability, and then after that comes your muscle weakness. Sometimes muscle weakness is so severe they cannot stand, walk, or sit without support. They're generally shorter and may weigh less than children their age. Skin is pale, may have anemia, and if the calcium levels drop enough, they can even have convulsions. You can see craniotapes or ping pong skull. You can press the skull and it will get indented. There's frontal bossing, prominence of the skull in the forward area, widening of the sutures. You know, the skull has sutures which fuse later on. You can see if the sutures get wide enough, you can see like a hot crossbun appearance of the skull, also called caput quadratum. The fontanelles persist, especially the posterior fontanelle, which is supposed to close around 3 months, can even be persistent beyond 6 to 7 months in case of a rickets, and also delayed tooth eruption and poorly mineralized teeth development. This is rachitic rosary. The cartilaginous part of the costocorneal junctions become enlarged, and you can see this rachitic rosary. Pectus carnatum is more common. Harrison's sulcus or Harrison's groove occurs. This is where the diaphragm attaches, and whenever the diaphragm pulls on the bones here, they can become indented. They can have chronic cough. They can have a pot belly called rachitic pot belly. They can have thoracic kyphosis called rachitic cat back. So limbs, you can remember that main thing we can see in the limbs is because occurs. I told you the physis enlarges both vertically and horizontally. So the enlarged ends of long bones, especially where the physis is present, is thickened and widened. Sausage-like swelling of fingers, which constrictions at the joints, string of pearls deformities, bow legs, knock knees, windswept deformity, where there's varus of one and valgus of the other, procurvatum, or you can see saber shins. You can see where the tibia is bowing anteriorly, and various deformities in the arms and legs. So, what are the radiologic findings? So the outer cortices appear thinner, and even the trabecular formation is fewer in cases of rickets. You should remember that the long bones are mainly affected in rickets, and smaller bones are usually less affected and look relatively normal. Whereas in case of rickets due to chronic renal failure, we can have Brown's tumors and other defects in smaller bones. Whereas in nutritional rickets, mainly long bones are affected, especially metaphyseal layers of long bones, ribs, pelvis, and scapula. So this is a very important slide here, where There should be a dense white zone here called the zone of provisional calcification, but in rickets, it appears less dense, appears fuzzy. By fuzzy, it means the margin is irregular. There's cupping. I'll show you on next slide. This is cupping. You can see there's nice cupping of the metaphysis because of the pressure from the growth plate. Fraying means there's outward. So instead of the growth plate being like this, it frays outwards. That's what fraying is. So you can see the margin of the growth plate is not regular or flat. It's irregular like a paintbrush, also called trees on plateau top appearance. Sometimes due to the weakened bones, there can be transverse bands of or Looser's lines or radiolucent lines, which are nothing but pathological fractures in case of rickets patients. You can see widened, lengthened growth plates along with widening. Same here, widened and lengthened growth plates, cupping, fraying. Same thing here, brush-like appearance of the thing, brush-like appearance of the metaphysis. You can see here, same thing. This is a normal growth plate. You can see the widened growth plate, fraying of the margins, cupping. Bone scintigraphy can pick up areas of increased intake. So in case of rickets, there'll be areas of increased uptake because of lack of mineralization. And you can see here, this was a case of rickets which was treated with vitamin D and ultraviolet light. And you can see this was initially how it looked. And you can see after the treatment, it recovers fully. And however, sometimes there'll be residual deformities which might have to be corrected with surgery. All right, that'll be it for the video. Thank you.